ಅಲ್ಲೇ ರೈಟ್ ಕ್ಲಿಕ್ ಮಾಡ್ಕೊಂಡು ಆಫ್ ಮಾಡಿ ಸರ್.
ಹೌದಾ?
ಸರ್
ಬಂತಾ?
ಹ್ಞೂ ಸರ್.
ಶುರುನಾ? 12 ಗಂಟೆಗೆ ಇಳಿರೋದು, 12ರಿಂದ 1. ಅದಕ್ಕೆ ಇನ್ನೊಂದು
ನೋಡ್ತಾ ಇರ್ತಾರೆ ಸರ್, ನೋಡ್ತಾ ಇರ್ತಾರೆ
ಅಂತೆ. ವಾಯ್ಸ್ ಎಲ್ಲ ಕೇಳಿಸುತ್ತಲ್ವ? ಹಾಂ,
ಎಸ್ ಸರ್.
ಕೇಳಿಸ್ತಾ ಇದೆಯಾ?
ಎಸ್ ಸರ್.
ಹಾಂ, ರೈಟ್, ಸರಿ, ನಾನು ಮಾಡ್ತೀನಿ. My dear students, now today I am going to take a class on lymphoreticular system, right? Here you might have seen in your medical postings or surgical postings, some patients comes with a history of enlargement of the swellings in the neck region. So that swellings in the neck region may be due to the soft tissue swelling, or maybe due to the lymph node enlargement, or maybe due to the parotid glands, etc. So here I am concerned mainly with this lymphoreticular system. So one of the cause for the enlargement of the, before going into the causes of enlargement of the lymph node, let us know the normal microscopic anatomy of the lymph node. So the lymph node has got a capsule, and then the subcapsular sinus, and then the cortical area consisting of the follicles which will have the two types of cells, that is the centrocytes and the centroblast. These are developed from the marginal or the mantle zone lymphocytes. So once they enter into the follicles, then they will become the small cleaved, and then the large cleaved, small non-cleaved, and then the large non-cleaved. This on exit out from the follicle, it forms the memory cell, and then the plasma cells, etc. So this is how the follicle develops. So follicle consisting of centrocytes, centroblasts, and these are the B cells. These are the B cells which are present in the follicles. Between the follicles is a paracorticular area which consists of the T lymphocytes. Paracorticular area consisting of the T lymphocytes. Then the medullary sinuses, medulla consisting of the medullary sinuses which are lined by the spindle cells, So this is the microanatomy of the lymph node. So after knowing the microanatomy of the lymph node, next is the clinical importance. So whenever there is enlargement of the lymph nodes, we call it as lymphadenopathy. Lymphadenopathy is the enlargement of the lymph nodes. We call it as lymphadenopathy. This lymphadenopathy may be localized, confined to a single site, or it may be the generalized enlargement of the lymph nodes. Generalized, where all the group of lymph nodes are involved, that is generalized lymphadenopathy. If it is confined to a single site, then we call it as a localized lymphadenopathy. Now, what are all the causes for the enlargement of the lymph node? The causes are infections. Infections are one of the cause for the enlargement of the lymph nodes. The next to the infections, the next cause for the enlargement of the lymph nodes are non-specific lymphadenitis. That is the second cause for the enlargement of the lymph nodes. And the third cause is the tumors. The tumors are one of the cause for the enlargement, and these tumors are again classified into the primary tumors, So that is a primary, that is a lymphoma. That is the malignancy of the lymph node itself. That is primary causes. Primary tumors are the lymphomas. One of the route of spread of the tumor is through the lymphatics. So all carcinomas spread through the lymphatics, so that they get deposited within the lymph nodes. That is the secondary deposit or the metastatic deposits. Metastatic deposits can cause the enlargement of the tumor. That is the third cause for the enlargement of the lymph node. And the fourth cause, some of the clinically associated lymphadenopathy. Some of the lymphadenopathy are associated with the clinical manifestations, clinically associated enlargement of the lymph nodes. So these are the four main causes for the enlargement of the lymph nodes. One is infections, the second one is non-specific lymphadenitis, which may be acute or chronic lymphadenitis, and the third one is tumors, which may be primary tumor, that we call it as lymphoma, and the secondary deposits, that is mainly the carcinomatous deposits in the lymph node, can cause the enlargement of the lymph node. And the fourth one is some of the clinically associated lymphadenopathies. Right, coming to the first one, what are all the infections which are responsible for the enlargement of the lymph node? The infections are mainly the bacterial infections. Bacterial infections. Some of the bacteria can cause the enlargement of the lymph nodes. What bacteria causes the enlargement of the lymph nodes? Mainly, it is tuberculosis is one of the cause for the enlargement of the lymph nodes, which may be local or generalized lymphadenopathy also. Tuberculosis. And the next is microbial agents, which is bacterial agents, that is the LGV, that is lymphogranuloma venereum, can cause enlargement. And sometimes even in the typhoid also there will be enlargement of the lymph nodes. Typhoid, LGV, and syphilis, and then the leprosy, syphilis, LGV, typhoid, tuberculosis, and then the staphylococcal and the streptococcal infections. Staphylococcal, syphilis, typhoid, tuberculosis, and then lymphogranuloma venereum, and even the Yersinia pestis, which causes that bubonic plague, where there will be enlargement of the inguinal lymph node. So these are some of the bacterial causes, examples of bacterial causes which leads on to the lymphadenopathy. Commonest is the tuberculosis. Any enlargement of the lymph node with the matting which are soft in consistency, we have to consider the tuberculosis first, right? So these are some of the bacterial infections which leads on to the enlargement of the lymph nodes. The next cause is viral. Viral causes, some of the viruses can also cause the enlargement of the lymph nodes. Particularly in pediatric age group, these are the viruses which causes the enlargement of the lymph nodes. I'll call you later, I'm taking class, okay? So viruses which are responsible for the enlargement. What viruses? The first one is Epstein-Barr virus. Epstein-Barr virus, which causes the generalized lymphadenopathy, that we call it as infectious mononucleosis. Infectious mononucleosis, viral cause. Epstein-Barr virus is one of the viral cause. And then next is the cytomegalovirus infection. Cytomegalovirus infection is the second infection, a viral infection, which can cause the lymphadenopathy. Next is the measles virus. Measles virus, particularly in pediatric age group, there will be enlargement of the lymph nodes due to the measles infections. And then important one is HIV infections, AIDS. That is HIV infections. There are three stages in this. First is the enlargement of the AIDS virus. human immunodeficiency virus, and then the herpes simplex virus. So these are the viral causes for the enlargement of the lymph node. And the third one is the fungal infections. Some of the fungal infections can cause the enlargement of the lymph nodes. That is fungal infections, that is cryptococcosis. Cryptococcosis. As such, the enlargement of the lymph node in fungal infections is rare. Only in immunodeficient individuals, the cryptococcosis can cause the enlargement of the lymph nodes, and even the histoplasma. Histoplasma can also cause the enlargement of the lymph nodes. Cryptococcosis and the histoplasma, these are some of the fungal infections which can cause the enlargement of the lymph nodes. The next is the protozoa or parasitic infections. Next is the parasitic infections. Some of the parasites can cause, for example, the filaria, parasitic or the protozoal. Filaria can cause the enlargement of the inguinal lymph nodes. Filaria, one of the protozoal or the parasitic infestations, and even the leishmaniasis can also cause the enlargement of the lymph node. Leishmaniasis, filaria, and then toxoplasma. So these are some of the parasitic infestations, that is filaria, and then toxoplasma and leishmaniasis. So these are the 4 parasitic infestations which can lead on to the enlargement of the lymph nodes. Now the infections, that is over. That is viral infections, bacterial infections, and then the fungal infections and the parasitic infestations. So these are the infectious agents which can cause the enlargement of the lymph nodes. The next thing which causes the enlargement of the lymph nodes are the clinically associated lymphadenopathy. Some of the clinically associated lymphadenopathy are sarcoidosis, where there will be enlargement of the which may involve all the lymph nodes. Generalized lymphadenopathy along with the pulmonary involvement, which is seen in this, where we see the non-caseating granuloma. Sarcoidosis, which is a systemic infection, systemic clinical manifestation, where there will be involvement of the lungs and also there will be generalized lymphadenopathy, sarcoidosis. And some of the immunologically mediated diseases, that is SLE, that is systemic lupus erythematosus or the leukoid erythematosus, there will be involvement of the lymph nodes, SLE. And then the third one is rheumatoid arthritis. Rheumatoid arthritis can also cause the enlargement of the lymph nodes. And some of these diseases like Kimura's disease, which is a systemic clinical manifestation along with this lymphadenopathy. And then there is one more condition called the Rossi-Dorfman disease, that is sinus histiocytosis. Sinus histiocytosis with massive lymphadenopathy. Sinus histiocytosis with massive lymphadenopathy. That is also one of the clinically associated lymphadenopathy. And one more important one, that is dermatopathic lymphadenopathy. Maybe benign conditions, maybe scalp infections can cause enlargement of the lymph nodes, cervical lymph nodes, or some of the cancerous conditions, or that is maybe benign conditions or the malignant conditions can cause the enlargement of the lymphadenopathy, that is known as dermatopathic lymphadenopathy. One more condition clinically associated is Castleman's disease. Castleman's disease is one of the pre-malignant condition where there will be generalized lymphadenopathy, and within that there are lymph nodes. Almost all lymph nodes are involved. So it's one of the clinical manifestation which can lead on to the enlargement of the lymph node. So this in later stages can go into the lymphoma. And next is some of the drugs can cause enlargement of the lymph nodes. For example, this phenytoin sodium. Drugs like phenytoin sodium, which is used in convulsions, can cause the enlargement of the lymph nodes. And one more condition called angioimmunoblastic lymphadenopathy. Angioimmunoblastic lymphadenopathy, where there will be vascular proliferations within the lymph node with increase in the number of immunoblasts within the lymph node, angioimmunoblastic lymphadenopathy. So these are some of the clinically associated lymphadenopathies. Clinically associated lymphadenopathy. Example: Kimura's disease, and then Kikuchi's disease. Kikuchi's disease, where there will be granulomas associated with necrosis, and no neutrophils here. Kikuchi's. Right, dermatopathic lymphadenopathy, Kimura's disease, Kikuchi's, sarcoidosis, SLE, and then rheumatoid arthritis, sinus histiocytosis, massive lymphadenopathy, Castleman's disease, and then angioimmunoblastic lymphadenopathy. And drugs can cause the enlargement of the lymph nodes. So these are clinically associated lymphadenopathies. Coming to the next one, that is the malignancy, that is metastatic deposit or the primary lymphoma, primary tumors of the lymph nodes, that is called lymphoma. And the secondary one of the route of spread of the tumor is lymphatics. Through the lymphatics, all carcinomas spread through the lymphatics, thereby involving the regional lymph nodes. This I think I have told you in the neoplasia class, right? So that is the causes of lymphadenopathy. Now coming to the one more cause, that is non-specific lymphadenitis. Non-specific, due to this some of the microbes or the products of the microbes can cause the localized lymphadenopathy. That is the acute non-specific lymphadenitis. Acute non-specific lymphadenitis. So here the acute enlargement, for example, this tonsillitis or the caries tooth, tonsillitis or caries tooth, and in males during this shaving, that antigenic some infections which can lead on to the enlargement of the cervical group or the submental group of lymph nodes. And similarly, the infections of the extremities, upper extremities, can cause the involvement of this axillary group. So it can involve the cervical group or the axillary group. That is, in case of the upper extremities, there will be involvement of this axillary group of lymph nodes. And the third one, it may be the inguinal group of lymph nodes, where the infections in the lower extremities can cause the inguinal group of lymph node enlargement. So inguinal, and even the infections of the gastrointestinal tract. For example, this acute appendicitis. Acute appendicitis can cause the involvement of this mesenteric group of lymph nodes. Mesenteric, acute enlargement. And these acute non-specific lymphadenitis, they are soft. So these are the causes, that is maybe cervical involvement or the axillary involvement or the inguinal group of lymph nodes or the mesenteric group of lymph nodes are enlarged due to the microbial infections, or the products of this microbes can cause the enlargement of the lymph nodes, right? Now, what are the clinical features? Clinically, how do you see this? What are all the clinical features that we see in case of acute non-specific lymphadenitis? The first thing, they are acute in onset, sudden in onset, and they are soft and tender. So try to touch the lymph node, he feels pain. So soft in consistency, and they are tender. The patient doesn't allow to touch. Tender, they are soft in consistency, and the skin on the surface of these enlarged lymph nodes are reddish. So the skin over the surface of the lymph node, it is reddish in color. So that is one of the acute inflammatory signs, that is calla, ruba, etc. Right? So that is soft in consistency, tender, and then skin over the surface of this enlarged lymph node, it is reddish in color. Suppose if it is due to the bacterial infections like streptococcus or staphylococcal infection, then the lymph node will be converted into a bag of a pus. The lymph node will be converted into a bag of pus, so which will try to find the way outside. So that resulting in the sinuses, so that will become a fluctuant in the initial stages. Later on it gives way, the skin gives the way, so there will be formation of the sinuses. So this is the clinical feature that we see in case of acute non-specific lymphadenitis, right? They are soft in consistency, tender, and the skin over that it is a reddish in color, and if it is acute bacterial infection, then the whole lymph node will be converted into a bag of pus, then that will be a fluctuant, but later on the skin gives way, resulting in the sinus formation. Right. So that is the clinical features that we see in case of acute non-specific lymphadenitis. Coming to the microscopy of this acute non-specific lymphadenitis, microscopically these lymph nodes will show the enlargement of the germinal centers. Which will be infiltrated by the neutrophils, and there will be an increase in the number of macrophages, and these macrophages will engulf the nuclear material. Germinal centers are increased in size. There will be infiltration of the neutrophils plus presence of macrophages which will contain the nuclear debris in their cytoplasm. And if it is bacterial infection, then there will be necrosis. So there will be increased death of the lymphoid tissue, that is macroscopic death of the tissue, lymphoid tissue, that is necrosis. So necrosed areas consist more number of neutrophils. And in addition to that, we have to see the sinuses. Sinuses are show hyperplasia of the histiocytes. Increase in the number of the histiocytes in the sinusoidal spaces. That is, sinusoidal hyperplasia is also seen. Right. If it is as I told, if it is bacterial infection, the entire lymph node will show the necrosis with nuclear debris and neutrophils. So this is the microscopic picture that we see in acute non-specific lymphadenitis. Coming to the next term, that is a chronic non-specific lymphadenitis. So here, in case of chronic non-specific lymphadenitis, it may be due to the drugs can cause this chronic non-specific lymphadenitis, or some of the viral infections can cause chronic non-specific lymphadenitis, and then the virus infection, drugs can cause, and some of the bacterial products can cause and some of the immunologically mediated diseases can cause the chronic non-specific lymphadenitis. So this has been classified into three types. One is follicular hyperplasia, reactive follicular hyperplasia, that is number one, reactive follicular hyperplasia, and then the diffuse reactive hyperplasia, and the third one is sinus histiocytosis. So these are the three patterns that we see in case of chronic non-specific lymphadenitis. One is follicular hyperplasia, and the second one is a diffuse reactive hyperplasia, where there will be diffuse effacement of the architecture. What do you mean by the architecture? Architecture means it should have a capsule, subcapsular sinus, and then the cortex consisting of the follicles, and then parafollicular area which consists of the T lymphocytes and the medullary sinuses. That is the normal architecture. And in case of diffuse reactive hyperplasia, we are not going to see any follicles. So entire lymph node will be replaced by sheets of T lymphocytes and the immunoblasts, right? So that is the diffuse one. Whereas follicular hyperplasia means it will have the follicles. Follicles will, the follicular pattern is maintained. Whereas in case of sinus histiocytosis, we are going to see an increase in the number of sinusoidal spaces with the hyperplasia of the histiocytes. Coming to the first one, that is follicular hyperplasia. What are all the causes for this follicular hyperplasia? The causes for this follicular hyperplasia are the reactive follicular hyperplasia are the rheumatoid arthritis, number one, and then HIV infection, that is human immunodeficiency virus infection, and then the toxoplasmosis. These are some of the examples which can cause the follicular reactive hyperplasia, which may be rheumatoid arthritis, HIV, and then the toxoplasmosis. Some of these bacterial products can also cause the follicular reactive hyperplasia. So here the lymph nodes are soft to firm in consistency. Lymph nodes are soft to firm in consistency. These lymph nodes are soft to firm in consistency, and usually they are localized. Usually they are confined to a single site. And if we see the microscopy of these lymph nodes, microscopically we see the follicles which are of varying size. The follicles are of varying size. Some are larger, some are smaller, some are of medium size. That is pleomorphism of the follicles is seen. This is important because one of the primary malignancy of the lymph node is lymphoma, non-Hodgkin's lymphoma. In that one of the type is follicular lymphomas, which is a malignant condition which has to be differentiated from this reactive condition. That's why we should know how to differentiate these two. So here the follicles are of varying size. Follicles are of varying size. Some are smaller, some are larger, some are of medium size. And these follicles will show the germinal centers. These follicles will show the germinal centers. There is alternating darker area consisting of centroblasts, and then the lighter area consists of centrocytes. So alternating darker and the lighter area, that means the cells are in varying stages of maturation, and there is presence of germinal centers. And along with that, we are going to see some macrophages where they will be pushing up of the nucleus to one side, and the cytoplasm showing the nuclear debris, that is called tingible body macrophages. Presence of tingible body macrophages, so which goes in favor of a reactive follicular hyperplasia rather than follicular lymphoma. So follicles are of varying size. And they are usually confined to the cortex region, and these individual follicles show alternating darker and lighter areas. That is, darker area consisting of centroblast, the lighter area consists of centrocytes, and good number of mitotic divisions also. Mitotics are also seen. That means there is varying stages of maturation plus presence of mitotics, presence of tingible body macrophages. And along with that, if you concentrate the periphery of these follicles, there will be abutting of T lymphocytes surrounding the individual follicles. So there is no clear delineation between one follicle and the paracortical area. So clear-cut boundary is not seen in case of this reactive follicular hyperplasia. So this we should concentrate. Towards the periphery, there is abutting up of the lymphocytes, so there is no clear demarcation around the individual follicles, which goes in favor of a reactive follicular hyperplasia. Now, to differentiate this from the follicular lymphoma, in case of a follicular lymphoma, the follicles are usually of uniform in size. So they are uniform, and they are distributed both in the cortex and in the medulla. The entire lymph node is replaced by the follicles which are of the same size, same morphology. And within the follicles, we are going to see the either the uniform cell population, that is monotonous cell population. Monotonous cell population, either the small cells predominantly or the larger cells or the mixture of two cells, that is larger and that is mixed type. And the absence of tangible body macrophages, absence of tangible body macrophages. So there are no tangible body macrophages. And then the next is absence of tangible body macrophages. And then the next difference here, surrounding the individual follicles, there is a clear demarcation. There is a clear demarcation is seen around the follicles. Clear demarcation is seen around the follicles, which is seen in case of this follicular lymphoma. These follicles are distributed both in the cortex and in the medulla, and they are uniform. They consist of either single cell population or only two cell population. And then the absence of this tangible body macrophages, absence of this tangible body macrophages, and this germinal centers are absent. So we don't find the germinal centers in the follicular lymphoma. And surrounding the individual follicles, there is a clear-cut demarcation between the follicle and the paracorticular area, which is seen in case of a lymphoma. And one more finding is BCL2. BCL2, which is positive in case of a follicular lymphoma, but not so in case of reactive follicular hyperplasia. BCL2 is positive in case of a follicular lymphoma, but not so in case of a reactive hyperplasia, reactive follicular hyperplasia. This is how we differentiate the follicular lymphoma from the reactive follicular hyperplasia. Clear? After knowing the follicular hyperplasia, reactive follicular hyperplasia, the next pattern is a diffuse involvement of diffuse pattern, diffuse reactive hyperplasia. This diffuse reactive hyperplasia is mainly seen in the viral infections. Mainly seen in the viral infections, we see this diffuse reactive hyperplasia. So where the entire lymph node doesn't show the normal architecture, we don't see the follicles. So entire lymph node will be replaced by the that is the lymphocytes. So entire lymph node is replaced by the lymphocytes and also the immunoblasts. Immunoblast with the 3 to 4 nucleoli, etc. It is mainly the T cell mediated immunological reaction that leads on to the enlargement of the lymph node. That is a diffuse reactive hyperplasia, which is mainly seen in the viral infections. The next one is the sinus histiocytosis. The sinus histiocytosis. This is excuse me. So this is sorry. Sinus histiocytosis. This is seen mainly in cases of this carcinoma draining the lymph nodes, which drains the carcinoma. We see this sinus histiocytosis. For example, the carcinoma of the breast, which will drain into the axillary lymph node. Sometimes we may not find the tumor cells within the lymph node, but there is sinus histiocytosis. So the lymph nodes which drain the carcinomatous deposits may show the sinus histiocytosis, or sometimes some of the trivial injuries. Some trivial injuries can also cause the sinus histiocytosis. So here, what we see here is the enlargement of the sinusoidal spaces. Enlargement of the sinusoidal spaces with the increase in the proliferation of the histiocytes. An increase in the proliferation of the histiocytes. So enlargement of the sinusoidal spaces plus the histiocytic proliferation that is seen in case of the sinus histiocytosis. In between, the darker lymphocytes, lymphoid tissue is seen. So that is about the sinus histiocytosis, or that is about in total the chronic non-specific lymphadenitis, which may be reactive follicular hyperplasia, and then the diffuse reactive hyperplasia, and then the sinus histiocytosis. Among them, the reactive follicular hyperplasia is important because that is the one which we have to differentiate it from the lymphomas, right? Coming to the next one, let me tell about something about this TB lymph node also. This I think we have covered in practicals. So just for the completion, or because this is an important topic, that is TB lymph node. This is the one which we come across routinely in our clinical practice, where the patient presents with evening rise of temperature, loss of appetite, loss of weight, and sometimes cough with expectoration, plus the enlargement of the lymph nodes, which may be localized lymphadenopathy or a generalized lymphadenopathy. Usually the cervical group of lymph nodes are involved, right? So it is usually a secondary involvement. So primary is in the lung. So that leads on to the draining up of this tubercle bacilli into the lymphoid tissue, that thus leading on to the enlargement of the lymph nodes. And these patients presents with fever, etc., plus the lymphadenopathy. The lymph nodes are soft in consistency, and there is matting which is very characteristically seen in case of the tuberculous lymph node. What do you mean by matting? One lymph node will be adherent to another lymph node. You cannot delineate the boundary between one lymph node and the another lymph node. That is called matting. Why matting? That is because of periadenitis. Pericapsular inflammation, that is periadenitis, leads on to the addition of one lymph node with the another lymph node, that is called matting. Very characteristically seen in case of this tuberculous lymph node. And these lymph nodes are of varying size, soft in consistency, they are of varying in size, and the matting is seen, and cut section shows yellowish cheesy material. Cheesy material, that is known as caseation. Caseation very characteristically seen in case of this tuberculous lymphadenopathy. They are soft, matting in consistency. Cut section shows yellowish cheesy material, that is known as caseating necrosis. Caseating necrosis very characteristically seen in this tuberculous lymph node. And microscopically we see in the lymph node we see large areas of caseating necrosis. Which is an eosinophilic, granular eosinophilic material. Along with this granular eosinophilic material, we are going to see some well-defined features which consisting of the epithelioid cells, which are modified macrophages, which will have the chicken footprint appearance. And the cytoplasmic boundary of these cells, it is ill-defined. Chicken footprint appearance of these epithelioid cells, aggregates of these epithelioid cells. Along with this aggregates of the epithelioid cells, we are going to see some cells with multiple nuclei, which is present in a pattern, that is horseshoe pattern or the necklace pattern. So these we call it as Langhans giant cells. And these are the epithelioid cells. And in between we are going to see the granular eosinophilic material, that is caseating necrosis. So this whole thing is a granuloma. So presence of caseating granulomas is one of the hallmark of this tuberculous lymphadenitis. So in case of tuberculous lymphadenitis, we are going to see the caseating necrosis and well-defined lesions consisting of aggregates of epithelioid cells, which are spindly shaped and with which will have that chicken footprint appearance, and the cytoplasmic boundary is ill defined, and the union of these epithelial cells to form one giant cell called Langhans giant cell. So this is caseating granulomas, which is one of the feature that we see in case of this tuberculous lymphadenitis. So this is a short note question. Tuberculous lymphadenitis is short note question. So whatever I have told them in the Viva, they may ask you what are all the causes of this lymphadenopathy. Not only in Viva, if you get a case of a slide of Hodgkin's lymphoma, they are going to ask what are all the causes of this lymphadenopathy. What is lymphadenopathy? What are all the causes of this lymphadenopathy? That is in the Viva OC. They may ask you. And TB lymph node, microscopy of the tuberculous lymph node is a short note question. Right? And the third one, that is sometimes reactive hyperplasia, can also be asked as a short note. Rarely they can be asked as a short note question. Coming to the important topic in this, that is the primary tumors of the lymph node. Primary tumors of the lymph node, that is which has been classified into Hodgkin's lymphoma and then the non-Hodgkin's lymphoma. Broadly non-Hodgkin's. So here primary tumor of the lymph nodes, we call it as lymphoma, which is defined as the malignant neoplasm of the lymphoid tissue. Malignant neoplasm of the lymphoid tissue, where there will be proliferation of the monoclonal proliferation of the cells native to the lymphoid tissue. So it is the malignant neoplasm of the lymphoid tissue, where there will be monoclonal proliferation of the cells native to the lymphoid tissue. Maybe B lymphocytes, T lymphocytes, are the histiocytes. So monoclonal proliferation of these cells leads onto the tumor that is called lymphoma. So lymphoma is defined as a malignant neoplasm of the lymphoid tissue characterized by the monoclonal proliferation of the cells native to the lymphoid tissue. Maybe nodal or even the extranodal, outside the nodes. That is for example Peyer's patches, lymphoid aggregates in the submucosa, tonsillar enlargement, etc. So that is the definition of the word lymphoma. It is defined as the malignant neoplasm of the lymphoid tissue characterized by the malignant proliferation of the cells native to the lymphoid tissue, which may be T lymphocytes, B lymphocytes, or the null cells, are the histiocytes, right? So that is the definition of the word lymphoma, which has been broadly classified into two types. One is Hodgkin's lymphoma and the second one is non-Hodgkin's lymphoma. Coming to the Hodgkin's lymphoma, the Hodgkin's lymphoma is one of the commonest neoplasm that we come across. So here the Hodgkin's lymphoma has been further classified into two types. So here, before that, Hodgkin's lymphoma, it's one of the malignant neoplasm which is seen in the two decades. One is around 20 years, that is the first peak incidence, and the second one is around 70 years. So first peak incidence of Hodgkin's lymphoma is around 20 years, and the second peak incidence is around old age, that is 70 years. So that is the incidence of this Hodgkin's lymphoma. And here the males and females are commonly affected, equally affected. And particularly in case of this lymphocytic predominant, which is more commonly seen in males than in the females. And these lymphomas are more commonly seen in low socio-economic condition. Low socio-economic condition, these are seen, this lymphoma is seen. The individuals with low socio-economic conditions will have this Hodgkin's lymphoma. And the commonest presentation is lymphadenopathy, that is enlargement of the lymph nodes is the commonest manifestations that we see in case of this Hodgkin's lymphoma. And here characteristic of clinical feature that we see in Hodgkin's lymphoma is highly characteristics, where it starts in the axillary, one of the anatomical site. For example, it starts in the cervical groove. In the cervical groove, first a single lymph node is involved. Later on, a group of lymph nodes are involved. So first to begin with a single lymph node, later on a group of lymph nodes confined to that anatomical site only. So cervical group, single lymph node, group of lymph nodes, and then it spreads to the adjacent anatomical site, that is cervical. Next is axillary lymph node. So it's first to begin with a single anatomical site, single lymph node, and then a group of lymph nodes confined to that anatomical site. Later on, it spreads to the adjacent anatomical site. Later on, it spreads to other side of the diaphragm. Other side of the diaphragm, that is a inguinal group of lymph nodes, etc. Still later, it spreads to the other side, ipsilateral, to begin with cervical, axillary, and the inguinal, etc. So this is very characteristically seen in case of a Hodgkin's lymphoma. Along with the lymphadenopathy, there may be involvement of the spleen also. Splenic involvement and the liver involvement can also be seen. Only in the later stages there will be involvement of the bone marrow also. So to begin with, it's very characteristically seen in case of Hodgkin's lymphoma. It's to begin with a single anatomical site, single lymph node, then a group of lymph nodes, then the adjacent anatomical site, then the opposite side of the diaphragm, that is either side of the diaphragm, later on the other side, ipsilateral involvement. Very characteristically seen in case of Hodgkin's lymphoma. And this has to be differentiated from non-Hodgkin's lymphoma. In case of non-Hodgkin's lymphoma, all group of lymph nodes appear at a single presentation. This is not like first to begin with one anatomical site, later on another anatomical site where we see in Hodgkin's, but that is not so in case of a non-Hodgkin's lymphoma. Clinically, we have to differentiate whether it is Hodgkin's or non-Hodgkin's. That is all of a sudden all lymph node involvement, it is non-Hodgkin's. And involvement of the Speier's patches and Waldeyer's ring, which is more commonly seen in non-Hodgkin's lymphoma, but not so in case of a Hodgkin's lymphoma. That is also one of the clinical difference. So usually Waldeyer's ring involvement and the tonsillar, etc., which is not seen in case of Hodgkin's lymphoma, but is seen in case of a non-Hodgkin's lymphoma. And that is skin anergy, that is skin manifestations which is seen in case of a Hodgkin's lymphoma, but not so in case of a non-Hodgkin's lymphoma. Except in case of T-cell lymphoma like mycosis fungoides, etc., there may be skin involvement, but skin anergy which is seen in case of a Hodgkin's lymphoma, but not so in case of a non-Hodgkin's lymphoma. And here, these patients may present just lymphadenopathy or hepatosplenomegaly, etc. That is some of the patients. Whereas other patients may present with the symptoms. What symptoms? That is fever. Fever is one of the manifestation, and then the night sweats. Fever, night sweats, and then prostration, and then loss of weight, loss of appetite, and loss of appetite, and then loss of appetite, and of course the anemic signs and symptoms. So these are if you take up 100 patients, in that majority of the patients may have only the lymphadenopathy, and in some of the patients along with lymphadenitis or lymphadenopathy, there will be constitutional symptoms like a fever, night sweats, and then prostration, and then loss of weight, loss of appetite, and anemic signs and symptoms. So these are not seen in all the patients with Hodgkin's lymphoma. That's why when I take up the staging, I will tell you what is the Ann Arbor staging, right? What are all those, how many patients will have the symptoms, and depending on the symptom presence or absence of symptoms, that has been staged separately, right? So that is about the clinical features, and this is the one which is usually associated with this Epstein-Barr virus. Epstein-Barr virus is one of the virus which may be responsible for the causation of the lymphoma, except in case of one of the variant of this Hodgkin's lymphoma, that is lymphatic predominant type, doesn't have this association with this Epstein-Barr virus. Right? It doesn't have association with the Epstein-Barr virus, whereas the classical type of Hodgkin's lymphoma will have an association. So about 60%, 50% will have this association with this Epstein-Barr virus. To begin with, this Epstein-Barr virus causes the polyclonal proliferation of the lymphocytes, resulting in infectious mononucleosis. Later on, it leads on to the development of this Hodgkin's lymphoma, or even sometimes even non-Hodgkin's lymphoma also, right? So one of the viruses may be associated with this Hodgkin's lymphoma. So that is about the clinical aspects of this Hodgkin's lymphoma. And the important finding that we see in Hodgkin's lymphoma is presence of Dorothy Reed-Steinberg cell. Dorothy Reed-Steinberg cell is one of the finding. We have to see the presence of this Dorothy Reed-Steinberg cell. So if you find the Dorothy Reed-Steinberg cell, definitely it is definitely Hodgkin's lymphoma, right? So if you don't find the Dorothy Reed-Steinberg cell, we usually doesn't call it as an Hodgkin's lymphoma, right? And here we classify the Hodgkin's lymphoma into two types. One is a classical type. So, and the first one is lymphocytic predominant type. Lymphocytic predominant type, that is one. And the second one is the classical type. So lymphocytic rich type, and then the mixed cellular type, and then the third one is the nodular sclerosis type, and the fourth one is lymphocytic depletion type. So these four lymphomas categories which comes under the classical type of Hodgkin's lymphoma, and another one is lymphocytic predominant. So this classification is depending upon the clonal densities that are present on the surface of this Dorothy Reed-Steinberg cell. So here the classical type will answer for CD15 and CD13. In the classical type of Hodgkin's lymphoma, that Dorothy Reed-Steinberg cell answers for CD15 and the CD30, which is negative in case of lymphocytic predominant type. So this is the WHO classification. Earlier, we used to classify Hodgkin's lymphoma under Rice classification. It is a place in North America, Rice classification. According to Rice classification, only 4 types, rich type, and then the mixed cellular type, and then the nodular sclerosis type, and the fourth one is lymphocytic depletion type. So these comes under the classical type. This here the classic, that is the tumor cell, that is Dorothy Reed-Steinberg cell, which will answers for CD15 and 13, which is negative in case of lymphocytic predominant type. So this is the classification of Hodgkin's lymphoma. So this is a short note question. They may ask you classify the Hodgkin's lymphoma. Just a short note question. You have to classify it as lymphocytic predominant type and then the classical type. Classical type, once again, lymphocytic rich type, mixed cellular type, and then the nodular sclerosis type, and the fourth one is lymphocytic depletion type. So it's a short note question. What are all the different types of Hodgkin's lymphoma? So you should be able to write these classification. That is better you write WHO classification. If it is old timers, then ask for the Rice classification, right? Now, after the classification, the presence of RSL is a must to diagnose this Hodgkin's lymphoma. So, what is that? That is also a short note question. Enumerate the different types of RSL and where they are found, in which type of subclassification of lymphoma those particular RSLs are present. Reed-Steinberg cell or a Dorothy Reed-Steinberg cell. They may ask it as RSL or the Dorothy Reed-Steinberg cell. So here, that is one of the malignant cell that we see in case of Hodgkin's lymphoma. So there are different types of this Dorothy Reed-Steinberg cell. The first one is a classical type, and the second one is a polyploidal type. Polyploidal type, that is the second one. And then the third one is a lacunar cell, lacunar type of Dorothy Reed-Steinberg cell. And the fourth one is a lymphocytic histiocytic type, lymphocytic histiocytic or anaplastic type. We can call it as, rather than lymphocytic histiocytic, we call it as anaplastic type. Anaplastic type. So these are the four types of Dorothy Reed-Steinberg cell. One is a classical type, and the second one is polyploidal type, and the third one is a lacunar type of Dorothy Reed-Steinberg cell, and the fourth one is anaplastic type of Dorothy Reed-Steinberg cell. Now let us know the morphology, how they appear microscopically in the microscopic appearance of this Dorothy Reed-Steinberg cell. The first one is a classical type. It is around 30 to 45 micrometers in diameter, and it shows a nucleus which is a bilobed, nucleus. And these nucleus show the nucleoli, eosinophilic nucleoli, almost the size of an RBC, like eosinophilic nucleoli. Nucleoli is seen with, and two nucleoli. Surrounding the nucleoli, there is a clear space, that is a perinucleolar halo. Perinucleolar halo is seen. And around the halo, we see the condensation of the nuclear chromatin, which will extend up to the nuclear boundary. And so these are this is nucleoli. This is also nucleoli. This is a nucleus. This entire thing is a nucleus, and the cytoplasm, which is amphophilic, or the slightly bluish color. So this is a binucleated classical type of Dorothy Reed-Steinberg cell. Binucleated classical type of Dorothy Reed-Steinberg cell. The next one is a cell which will have a polyploidal, that is a multilobated, and individual lobe will have the nucleoli. And cytoplasm, which is light blue in color. So this is a polyploidal, or otherwise known as popcorn type of Dorothy Reed-Steinberg cell. Dorothy Reed-Steinberg cell. This classical type, it has been compared to that owl's eye appearance or bispeckled appearance. So this is a classical type, and this is a polyploidal type or the popcorn type of Dorothy Reed-Steinberg cell. And the third one is that is also almost like that of the classical type of Dorothy Reed-Steinberg cell, and that also has got the bilobed nucleus or the mirror image, and that also shows a nucleoli and then perinuclear halo. Here the cytoplasmic boundary will show halos. Cytoplasm will show halos, just an eosinophilic extension from the nuclear boundary to the cytoplasmic boundary. In between there are clear spaces. Between the cytoplasmic extensions from the nuclear boundary to the cytoplasmic boundary. So this is clear halo. So this is the lacunar type of Dorothy-Reed-Steinberg cell. Lacunar type of Dorothy-Reed-Steinberg cell. So this is a classical type or the mirror image type of Dorothy-Reed-Steinberg cell, and this is a polyploidal type or popcorn type, and the third one is the lacunar type of Dorothy-Reed-Steinberg cell. And the fourth one is anaplastic. Here the nuclear size may vary, and that they are all pleomorphic. Pleomorphic, they may have the multiple lobes, multiple nucleoli, etc. Their size also varies. So this is anaplastic type of Dorothy-Reed-Steinberg cell, right? Now we know the different types of Dorothy-Reed-Steinberg cell, and in the exam this will be asked as a short note question. Dorothy-Reed-Steinberg cell. So it is a binucleated cell which is found in case of Hodgkin's lymphoma. There are four types of Dorothy-Reed-Steinberg cell. One is a classical type of Dorothy-Reed-Steinberg cell, and then the polyploidal or popcorn type of Dorothy-Reed-Steinberg cell, and then the lacunar type of Dorothy-Reed-Steinberg cell, and the fourth one is the anaplastic type. Now, what lymphomas will have what type of RS cells? In the in the classification, microscopic classification, we classified it the classical type and the lymphocytic predominant type. So here, this lacunar type of Dorothy-Reed-Steinberg cell is seen in case of nodular sclerosis type. Nodular sclerosis type of Hodgkin's lymphoma will have the lacunar type of Dorothy-Reed-Steinberg cell. Whereas the classical type of Dorothy-Reed-Steinberg cell are seen in the mixed cellular type. And also in case of lymphocytic rich type. Lymphocytic rich type and the mixed cellular type will have a classical type of Dorothy-Reed-Steinberg cell. Actually, in case of lymphocytic rich, these binucleated cells are very less in number. It is mainly the lymphocytes which are predominantly seen, right? And this popcorn type or the polyploidal type, which is seen in case of this one lymphocytic predominant type. Lymphocytic predominant type, this popcorn type of Dorothy-Reed-Steinberg cells are seen, whereas anaplastic are seen in lymphocytic depletion type. Correct? Clear? So here nodular sclerosis type of Hodgkin's lymphoma will have the lacunar type of Dorothy-Reed-Steinberg cell. And then the classical type of Dorothy-Reed-Steinberg cells are seen in mixed cellular type and then the lymphocytic rich type. And then the popcorn type or the polyploidal type of Dorothy-Reed-Steinberg cells are seen in case of lymphocytic predominant type of Hodgkin's lymphoma. Whereas anaplastic type of giant cell, that is the Dorothy-Reed-Steinberg cell, which is seen in case of lymphocytic depletion type. So these are the four different types of Dorothy-Reed-Steinberg cell and the lymphomas, different types of Hodgkin's lymphoma associated with this four Dorothy-Reed-Steinberg cell. Short note question, write its first classical type, write it as lymphocytic rich type or the mixed cellular type. Right, this lacunar type of Dorothy-Reed-Steinberg cell, write it as nodular sclerosis type. And the popcorn and then the anaplastic type, lymphocytic depletion type. And then popcorn type or the polyploidal type, write it as lymphocytic predominant type of Hodgkin's lymphoma. That's what we expect you from this short notes RS cell. Okay. So after knowing the RS cell, which is the cell that we have to see it in case of Hodgkin's lymphoma, right? And coming to the next one, in addition to this binucleated cells, we are also going to see some cells which are around 30 micrometers in size, and they show a single nucleus, and within the nucleus a predominant nucleoli, single nucleoli, and the perinuclear halo, and then the nuclear chromatin, and the cytoplasm, which is a mixture of bluish with a slightly eosinophilic tinge. So that is a Hodgkin's cell. that is a mononuclear cell, Hodgkin's cell, which is also seen in case of this Hodgkin's lymphoma. So binucleated cell is a must to diagnose it as Hodgkin's lymphoma. Along with that, we are going to see this mononuclear cells also, that is a Hodgkin's cell. So now we know the different types of Hodgkin's lymphoma, clinical manifestations, and also the Dorothy-Richteinberg cell. I think in the next class, let me tell you about the microscopic appearances of this Hodgkin's lymphoma. How microscopically we see in case of this different types of Hodgkin's lymphoma, and also an Harper's staging of this Hodgkin's lymphoma, and other laboratory investigations which will be helpful for the diagnosis of this Hodgkin's lymphoma. Thank you very much. Thank you. ವಿಮಾನ ಕಳಿಸ್ತಿದ್ದೆ ನಾವು ಕಳಿಸ್ತೀನಿ ನನಗೆ ಒಂದ್ಸರಿ ಹೇಳ್ಕೊಟ್ಟು ಮಾಡ್ಕೊಳ್ತೀನಿ ಮುಂದೆ ಒಂದು ಹಾಕೋದು ಗೊತ್ತಾಗ್ತಿಲ್ಲ ಮುಂದಕ್ಕೆ ಕ್ಲಾಸಿಗೆ ಕಳಿಸ್ತೀರಾ ಇವರು ವಿಮಾನ ಕಳಿಸ್ತೀರಾ ಹಾಂ